From the Gulf States Newsroom, this is the Gulf States Gumbo, your weekly serving of stories from Alabama, Mississippi, and Louisiana. I'm Deputy Managing Editor Orlando Flores Jr., chopping it up this week. More than 1 million Americans have died of drug overdoses since the year 2000. Despite the staggering loss, one tool for treating opioid addiction has been tangled up in politics, stigma, and money for decades. Medication-assisted treatment, or MAT, has a long and complicated history in the U.S., including a direct connection in the Gulf South. The Gulf States Newsroom senior reporter Drew Hawkins spoke with Emily Dufton, a drug historian and author of the new book Addiction, Inc. The two discussed how the MAT approach to addiction treatment came to be, how its perception has changed over time, and where it could go in light of new funding intended to fight the opioid epidemic.
Emily, thank you so much for sitting down with me and talking about your new book, Addiction, Inc.
Thanks so much for having me, Drew. I'm happy to be here.
So I think we've got to do a little bit of table setting and just, start simple and basic with what MAT is, medication-assisted treatment. So how does it work and how can it help people struggling with opioid use disorder?
Medication-assisted treatment, or MAT, is known as the gold standard of addiction treatment because it uses one of 3 FDA-approved drugs, either methadone, buprenorphine, or naltrexone, to control withdrawal symptoms and prevent illicit drug use.
You spend a lot of time in your book going through the history of really all of the major drugs that are used for medication-assisted treatment. You've got methadone, naltrexone, and Suboxone, or buprenorphine, as many people may know it. But I think maybe starting even a little more broadly than that, just the history of MAT itself in the United States. Your book goes through this approach to addiction treatment, and I don't expect you to really, compress more than a century into a succinct, perfect answer. But broadly speaking, how has MAT been received in the United States?
Well, what's really interesting is that the 3 drugs that comprise what we know as MAT today are all products of the Nixon administration in 1971, when, in response to rising rates of heroin use and crime in the United States and the threat of addicted veterans returning from Vietnam, Richard Nixon launched SAODAP, the Special Action Office for Drug Abuse Prevention, on June 17, 1971. And SAODAP was charged with funding hundreds of addiction treatment clinics nationwide, including methadone maintenance clinics. Now, SAODAP didn't last very long. It was ultimately devolved into NIDA, the National Institute on Drug Abuse. But SAODAP and then NIDA continued to have a role in the field because they were foundationally responsible for the development of the 2 other MAT drugs we use, including naltrexone, which was released in the 1980s, and Suboxone, which is the commercial name for buprenorphine, which was released in the early 2000s.
I'd almost guarantee that a lot of people listening to this would not think that Richard Nixon played as big of a role as he did in expanding access to medication-assisted treatment. I mean, and your book is really full of these unsung heroes like that. But, of course, moving past Nixon, we start to really get into the ramping up of the war on drugs. And I wonder if you could talk a little bit about how the war on drugs played a role in shaping or maybe suppressing the development of medication-assisted treatment and its adoption.
Sure. The 1980s, during the presidency of Ronald Reagan, this is when our modern law enforcement, militarized, very punitive war on drugs really starts to take shape, primarily driven by the rise of the crack cocaine epidemic. But it also had a really troubling effect on methadone availability. So starting in 1981, once Reagan is in office, he starts to dismantle this federally funded, nationalized addiction treatment system that Nixon had put in place a decade prior. He defunds methadone clinics, which have to privatize in order to survive. Cuts all of NIDA's staff that used to run this system. And then, even as the HIV/AIDS epidemic starts to take off and tens of thousands of people start to die, he continues to repress methadone and not fund it and keep it unavailable, even as the number of people receiving the virus are mostly getting it through injection drug use. He does nothing to stem the tide, but instead just say no, instead actually reaches over to methadone access as well. The only MAT drug the Reagan administration supports is naltrexone, which is released in 1984. And because it's used by people who have totally withdrawn from opioid use to prevent additional opioid use, because it essentially sustains abstinence, that drug was supported by the Reagan administration, while methadone very clearly was not.
I think it's really interesting too that these changes in policies also follow a change in perception of people who use drugs, right? Because as you mentioned in your book, the early people who struggled with opioid addiction, like the late 1800s, early 1900s, back when you could order like morphine from a catalog, right? You could just buy it over the counter essentially. Most of those people were Civil War veterans who had been injured in the war or Southern housewives. And there wasn't this, national perception of them as bad people, as drug users. And then as time goes on and more young people start using it, start more people of color start using it, that perception and the policy around it starts to change as well. And I think an interesting kind of point to that is your choice to open and start the book in Shreveport, Louisiana, of all places. And I could go on and on and on about how fascinating I found this, but I would love to hear you talk about why you made that choice. What role Shreveport plays in this history, and why you chose to end and start the book, or start and end the book there.
So you're right. In the late 1800s, early 1900s, opioids like morphine and heroin were widely available. There were very few drug laws restricting their access, and about 4 out of every 1,000 people were actually physically dependent on these drugs. The laws start to shift in the early 1900s with the rise of widespread prohibitionism, not only for alcohol, which of course would be enshrined in a constitutional amendment, but for all drugs. And this is the way things kind of go as the laws escalate and get more serious on the local, state, and finally federal level with the Harrison Narcotics Act of 1914 until the end of World War I, when things shift radically with the arrival of tens of thousands of addicted veterans from Europe who have grown dependent on opium and morphine to deal with their casualties and injuries from abroad. So as they come back, there's widespread fear that these addicted veterans are going to cause massive chaos in American cities. And across the country, 44 morphine clinics are opened, which provide patients with a steady, legal, and inexpensive source of pure medical grade morphine to quell their withdrawal symptoms and essentially prevent the widespread terror of addicted veterans that was being warned about in the press. Shreveport actually has one of the longest, most successful, and most stable morphine clinics, which operates in the city from 1919 to 1923. And I open and close the book there because there was this wonderful 1923 article about it right before it closed that praised it for all of the wonderful work that it did and lamented its closure because of what are clearly political reasons. And I thought, oh, that kind of sounds similar to today.
Yeah, the parallels continue, and that you pulled some of the quotes from that article that some of the patients at that facility of various different walks of life talking about how helpful it was for them, and I do think it's really interesting that the U.S. was willing to kind of try a new approach in response to veterans coming back from war after World War One, and that's as you mentioned in the book is basically what happened with Nixon as well too, where the concern there was these quote unquote GI junkies coming back from Vietnam, right?
Exactly. So 50 years apart, you have the 1919, 1920 return of addicted veterans from Europe from World War I. And then that exact same fear causes the exact same response again on the federal level, actually on a wider level in 1971 with the fear of GI junkies returning home from Vietnam. It's two times in American history where the threat of addicted veterans has made massive changes in local and essentially federal drug policy.
The stigma that gets associated with people who use drugs can even extend itself to the actual medications that are available for medication assisted treatment. I'm thinking about the differences between methadone and buprenorphine or Suboxone, right? I wonder if you could talk a little bit about methadone versus Suboxone, which, chemically they do function in different ways, but ultimately they try to treat the same illness. But they are attained in entirely different ways. They were developed in different ways. So I'd love to hear you talk a little bit about the differences between those two.
It's a fascinating but somewhat also kind of arbitrary distinction. Methadone and buprenorphine are both opioid agonists, which means they replace the opioids in a patient's brain so they don't experience withdrawal. Essentially, it's a legal, medically regulated, FDA approved form of opioids for the treatment of opioid use disorder. But because they were both developed in such different ways, they're offered in two really different silos. Methadone, as we said, it was developed for addiction treatment in the 1960s, but spread nationwide in the early 1970s. But it was always faced with a whole lot of NIMBYism, like not in my backyard. Very few neighborhoods wanted a methadone clinic in their midst because the idea of giving a free narcotic to a known narcotic user was just kind of a bridge too far for a lot of people. So, although the demographics of methadone have remained fairly stable over the past 50 years, patient population is about 40% white, 40% black, and 20% Latino. Most methadone clinics, the only places where methadone is allowed to be dispensed in the United States, these are legal standards. They're mostly located either in very inaccessible and oftentimes crime-ridden areas of major cities, or if you're in a rural area, they're very distant, they're very inaccessible. It's difficult to get there and often uncomfortable to stand there every morning for your dose, which is what's required of you for methadone treatment. Now, this is very different from buprenorphine, which, after a 2000 federal ruling, is allowed to be dispensed by private doctors and private pharmacies. This changed who methadone and buprenorphine were kind of being marketed to, especially in the early years of buprenorphine availability. But even today, buprenorphine isn't that widely available. Recent reports I've read show that about 40% of American counties don't have access to either a buprenorphine prescriber or provider, which means that in a lot of places, neither methadone nor buprenorphine are available for the nearly 5 million people in the United States who have opioid use disorder. They're a massively undertreated population.
And then there's also just, you talked about the marketing, but there's that direct connection where a lot of the sales reps from Purdue Pharma, when they were pushing OxyContin, then switched over to selling Suboxone. So they could sell both the drug and then the cure for it. Right. And that also manifests in the types of patients that are able to access these medication assisted treatments too.
This was one of the most surprising things I found when I was researching this book. Essentially, the story of Suboxone mirrors the story of OxyContin almost exactly, at least in terms of drug sales. So, as we said, Suboxone was released in about 2002, 2003. And at first, because it was really expensive, it wasn't covered by insurance, and most people didn't have access to it because there were very few registered physicians who could prescribe it, most people didn't use it. It's kind of a commercial failure. But starting in 2005 and 6, when Purdue Pharma was coming under a lot of legal scrutiny for overprescribing OxyContin, it started laying off hundreds of its sales representatives and marketing directors. And the private company that made Suboxone scooped all of those people up and told them to start marketing Suboxone, the cure for opioid addiction, to the exact same doctors they used to market OxyContin, the source of opioid addiction. So they started following along their exact same tracks. One person at a sales conference said that they were overprescribing Suboxone up and down the Appalachian Trail. The pill mills in rural Virginia that were selling prescriptions for OxyContin, those doctors switched over by the early 2010s and started overprescribing and selling prescriptions for Suboxone instead. In fact, the private manufacturer of Suboxone was found to be so guilty of these same crimes that Purdue Pharma had perpetuated that they were fined $2 billion by the Department of Justice in 2020, and the CEO spent 6 months in jail. They not only mirrored Purdue's playbook, but they did so to even a far harsher criminal extent than Purdue itself experienced, at least back in 2007.
And that also, it manifests itself in who can access these medications too, right? Because you start to see class and racial divides as well. Because if you have the money, then you can access Suboxone in the comfort and privacy of your own doctor's office. But if you don't, your option is a methadone clinic, which means you have to get there early in the morning. You have to go every single day, and you have to go to places that are hard to reach or are crime ridden. And I wonder what that means for access for people. If you don't have the means, then what are you left with?
Well, you're left with not very good treatment options. And I think that exact problem is one of the reasons why we've been experiencing tens of thousands of opioid overdose deaths per year. We've made both forms of opioid agonist treatment with methadone and buprenorphine fairly unavailable and inaccessible for a wide swath of people. It's true, if you have the money and the access to a pharmacist and a prescribing physician, you can get access to buprenorphine fairly easily. And so in the beginning, the drug was almost exclusively being sold to people people with college educations, people who had developed opioid prescription dependencies through sort of doctor-oriented prescription problem. These were people who could afford to pay $16 a day or whatever it cost for a Suboxone prescription, whereas, methadone is about seven, right? It's a way higher price differential. This has changed actually over the past couple of years. The Biden administration signed legislation that got rid of the X waiver. So prescribing physicians no longer have to be registered with the DEA. Anyone can prescribe Suboxone for opioid use disorder treatment. Methadone clinics are increasing in number. We actually have about 2,000 plus clinics nationwide now, treating about 600,000 patients a year. Methadone is more available than it's ever been before. But that doesn't mean that necessarily these drugs are successful. And I think our really devastating opioid overdose death rate is a testament to the fact that even if they're more available now and no longer sort of constrained by these same racial and class structures, where there's still 80% of people struggling with opioid use disorder who aren't being treated by what we consider the gold standard addiction treatment in America. It's a mismatch, and it's a deadly mismatch that ultimately is costing tens of thousands of lives.
Just to switch gears, you open the book with a personal story about a friend of yours who died from an overdose. I'm curious why you felt it was important to include your own personal connection to the opioid crisis.
I felt I wanted to tell this story about my friend Dana, who actually died of suicide after 15 years of steady and escalating opioid use. He felt so sort of, his life felt so purposeless, and he was in such deep depression that he hanged himself in the woods behind our old middle school. And his story was really what got me thinking about what the best treatment for this problem is, because it wasn't only Dana I knew who died either from overdose or suicide. It was a number of my friends. It's really my generation, which is like late Gen X and early millennials, that has been impacted the most by opioid overdose deaths. We're at about 70% of total overdose deaths if you look at the harsh numbers. And Dana's story embodied that for me. The loss has been monumental. The number of graves in our local cemetery filled with young men is a really disturbing number. And I wanted to put a very personal face on this because oftentimes addiction treatment and especially medication assisted treatment, which is very controversial in some worlds, it's talked about, I think, without a very human face. It's very easy to dismiss these numbers if we pretend that they're not real people. But Dana was my friend, and I wanted people to understand why he was my friend and why his loss is a net loss for the world. He was a wonderful person. And of course, he's not the only one. A lot of families, one in three American adults, either knows someone with an opioid use disorder or has one themselves. I mean, this is a widespread issue, and I wanted Dana's face to be at least one aspect of it.
And then there is towards the end of the book, really right in the last couple of sections, you come back to the first person and you start talking about your experience traveling to Switzerland to see their approach to their own opioid crisis. That's something that I think maybe you and I have in common here. Although I went to the Netherlands for a month last year to learn about their approach, but I'd love to hear what you learned and what you saw in Switzerland.
I really enjoyed my trip to Switzerland because it's a country that was dealing with a very similar problem that the United States had in the 1980s, which was escalating rates of injection heroin use and escalating rates of HIV. But what they did was pretty rapidly was install what they call the four pillar system. They combined law enforcement with harm reduction, prevention, and treatment in sort of equal amounts to decrease the amount of open air drug use, decrease the amount of drug sharing, decrease the spread of HIV, and increase the social order that has been sort of notable about Swiss culture for hundreds of years. And it worked. They very quickly made all forms of treatment, including medication assisted treatment. They started with methadone, and now they have many more drugs, including legal access to heroin. And they combine that with safe injection sites, safe consumption sites. They combine that with prevention efforts, and they have a very strong law enforcement presence on the street to ensure that sort of the public nuisance of open air drug use, which we see quite openly in the United States, simply isn't present there because not only have they treated some of the more chaotic drug use, but they've also, in many ways, contained remaining drug use so that they recognize that drug use will never depart from Swiss society. It's always going to be a part of it, but it can coexist in social harmony with, basically like the school down the street. It was really extraordinary to witness.
No, I have to completely agree. I mean, it was extremely eye-opening to go to safe consumption sites and to see heroin assisted therapy programs. I mean, like, I'm from Louisiana. I didn't know about the history of Shreveport, and going to the Netherlands, going to Europe and seeing their approach. There were moments where even I could feel that internalized stigma kind of clutching my pearls a little bit, like, oh my gosh. But when you look at what it's done and how it's reversed the crises that they've experienced, I mean, it really speaks for itself. You can't deny it. And, we're still, as you know, in the midst of an ongoing opioid crisis. Part of that includes a whole bunch of lawsuits. We talked about Purdue Pharma earlier, but it's them and many other manufacturers, marketers, and distributors. And those lawsuits have resulted in hundreds of millions of dollars going to each state. Now, each state has their own plan, their own strategy about how to use the opioid settlement funds. But here in the Gulf South, Louisiana, Mississippi, Alabama, medication-assisted treatment is definitely not high on the priority list. So I wonder if you have any thoughts about how this once-in-a-lifetime pot of money, really is what it is, could be an opportunity for states to try expanding access to MAT, and how that could help with the crisis.
That's kind of the whole reason I wrote this book, right? Was I feel as though not having any sort of stable and gracious and accessible addiction treatment system in the United States, especially over the past 30 years since our prescription opioid crisis really heated up, it has been a major detriment to society. We've lost over 1 million people from drug overdoses since the year 2000. What the opioid settlement funds represent is a really interesting opportunity because the money is just coming. It's guaranteed through a lawsuit. That means it's not going to shift with changing political winds in Washington or the state, and it's not going to shift because the private companies supporting the grant suddenly aren't going to do it anymore. This is money that's guaranteed for the next 15 to 18 years. And ideally, it could build a sustainable, holistic treatment system that places like Switzerland and the Netherlands have, and that Americans have been asking for since the 1980s AIDS crisis, but we have not built. Now, whether that's because of the internalized stigma we have towards drug use and drug users, or we just don't have an interest in this form of treatment because we can't quite accept a substitution theory or whatever, I don't know. I'm not trained to say, but I would say the opportunity is there. And if we understand that we did try this in the 1970s, and it really did have amazing social effects, drug overdose deaths went down, drug emergency room trips went down, drug arrests went down, and crime went down when we made medication-assisted treatment available. There are net benefits to this, and they've been proven. If we look back to the 70s and see when it worked, and also see the mistakes we've made along the way, perhaps that could be inspiration to use this money to build something sustainable and holistic to prevent those future overdose deaths. But sometimes I'm too much of an optimist. I don't know what's going to happen with it.
I think there's no harm in being optimistic.
Right, hopefully.
Emily Dufton is author of the new book, Addiction Inc. And Emily, thank you so much for sitting down and talking with me.
Thank you so much for having me. That's been great.
And wait a second, Emily, before you go, we have a segment on the show called Gulf States Gems. It's how we end each show, and it's just a chance to shout out something that you love about the region, a bookstore, coffee shop, restaurant, person, place, thing, whatever comes to mind. So I would love to know, what is Emily Dufton's Gulf States Gem?
Oh, I want to call out the New Orleans Pharmacy Museum, which is one of the best pharmacy museums I've ever been to in my life, and I have seen them all over the world. It is a beautiful building full of amazing artifacts in a pristinely kept collection. There's an upstairs and a downstairs. There's also a soda fountain, which I just thought was so cool. And it's absolutely stepping back into the past. The staff was great. They were really knowledgeable. And I just think it's one of the coolest places I've ever been. So shout out to the New Orleans Pharmacy Museum.
And you know what's crazy? I didn't know about the history in Shreveport, and I've never been to the New Orleans Pharmacy Museum, and I live in New Orleans. So I will have to change that soon.
You got to check it out. It's great. It's right near the Napoleon House. Afterwards, you can get dinner.
Perfect.
This week's show is cooked up by the Gulf States Newsroom team. Our theme music is by DJ Supreme. Special thanks to our partner stations, WBHM, Mississippi Public Broadcasting, WWNO, and WRKF. You can find us in your podcast feeds every Friday. Look us up and be sure to subscribe. I'm your host, Orlando Flores Jr. Thanks for listening, and don't forget to stir your root.